Hello everybody, I hope you can hear me. My name is Andi Shatabashi from Vienna, and unfortunately my co-chair Rob Peters had to leave Valencia yesterday due to some private reasons. So Martin Schrapper will co-chair with me this session, which will deal with a very old drug, namely methotrexate, but we will speak a lot about high-dose methotrexate, and we will have 3 talks. And I think Martin will start with the first presentation and telling us, is there any role for high-dose methotrexate left for ALL? So welcome, Martin. The floor is yours.
So good afternoon. Yeah, good afternoon, everybody. The first one is mine. There is no closure slide because this drug is so old that you cannot get any money from Speakers Bureau, and this is not funded by a pharmaceutical company except for support for educational purposes, which does not apply to the speakers. Tomorrow there's a company-sponsored event. If you want to learn more about methotrexate, again, tomorrow is the chance. So it is funny to dig up information for such a topic, and so I want to introduce the scope of this presentation. And it is amazing, we have so many different schedules, doses, leucovorin rescue schemes, sometimes with, sometimes without IT methotrexate. It's really confusing, and I hope at the end of this session you are even more confused. So then it was worth coming here and having lunch together with the lecture. And one of the questions that I asked myself, is methotrexate really an issue at the moment when we discuss ALL? We have already heard some lectures today, and it seems the world is spinning around, at least the ALL world is spinning around CAR T cells, blina, and asparaginase. But now we come back to the basics, and methotrexate may be an issue, and I think it will be an issue in the future, and I will mention this at the end. We sometimes wonder, where is the evidence that this is really an important anti-leukemic drug? What we really know for sure is that there's evidence for toxicity, and we are faced with different data and different results from the various study groups, and I will try to shed some light on that. And for sure there's also potential neurotoxicity, but I'm very glad I don't have to talk about it because Chris will take over later on. But please let me remind you, there are serious problems associated with high-dose methotrexate, sometimes even with low-dose methotrexate, which is liver and nephrotoxicity. And I don't know, some of you certainly have experienced the situation that you start infusing methotrexate at a given dose and suddenly there's complete kidney failure, and you have high levels of methotrexate in the patient, and you have to make sure that this patient will survive. Usually, if you don't counteract, this patient will die. So this is a severe problem which is unique. I'm not aware of such situations if you enter an infusion of vincristine or RRC or something like this. So I go back a few years to look at the basics for the dose-response discussion, and also why is methotrexate in this dose range called high-dose methotrexate, which is a wide range, not a single dose. Why is it maybe relevant for CSF, CNS protection or CSF concentration? And the study which, for me at least, there are many studies. Don't even start to look at PubMed. It is confusing. But Joseph Borschi and Peter Moe, they did a really nice study with a wide range of methotrexate infusions in the 80s using data from NOFO. And they looked at very, very many different schedules. They measured the concentration of methotrexate in the serum and also in the CSF. And they established for the first time that there's a clear age dependency. So it's not the same thing if you do this dose, let's say high-dose methotrexate in young children, or in adolescent children, and this was clearly established in that study, not only with regard to serum, but also with regard to CSF concentrations. Another thing which is interesting, that the number of courses, and this is important because our different schedules, different protocols have different schedules, the number of courses depends, the impact on the CSF concentration depends on the number of courses given at a certain dose range. On the left side, you see the so-called intermediate dose methotrexate, 0.5 grams per meter square. And you see from cycle to cycle, the CSF concentration, or the ratio of CSF to serum concentration, goes down, whereas if you give high dose, 1 to 8 grams of methotrexate per meter square, it's about the same each time. For me, one of the most important studies which also triggered the use of high-dose methotrexate at 5 grams in BFM was this one. This one comes from a URTC, and it was published in 1990. With nearly 60 patients and nearly 200 courses analyzed, and they found that the methotrexate concentration in the serum and in the CSF at the end of the 24-hour infusion has quite a wide range, but the most important finding was that in general, with this intravenous dose, you can achieve cytotoxic levels in the CSF. And therefore, I think, lesson number one, high-dose methotrexate at 5 grams per meter square given over 24 hours is able, in most cases, not in every case, but in most cases, to achieve cytotoxic anti-leukemic levels in the CSF. So it's a very important study. They concluded, and therefore I copied this in here, they concluded it's not necessary to give IT methotrexate. And we said, well, if it's only true for 80% of the patients, there are 20% in which it's not working. So it's better to be on the safe side to give some additional IT methotrexate. Now, many years later, these studies came out with interesting and sort of contradictory results. Very recent studies from the COG with many patients. High-risk BLL is the first one, 0232. They published quite recently that dexamethasone and high-dose methotrexate can improve the outcome of children with high-risk BLL. Okay, when we saw the paper, we were all a little bit surprised because we did not necessarily expect this. But anyway, the data are quite convincing. High-dose methotrexate, the yellow line, is better than C-methotrexate. C-methotrexate is not continuous methotrexate, it's Capizzi methotrexate. What is Capizzi methotrexate? I think Capizzi was a pharmacologist. And he had the concept of combining asparginase and methotrexate without leucovorin. And that's what they did. So they found this advantage of high-dose methotrexate. And then they went into the interaction between the initial steroid randomization and the methotrexate randomization. And, again, yellow line, dexamethasone with high-dose methotrexate is the best arm. But if you compare dexa and prednisone in general, this is different than from AOBFM. There's no difference in outcome. So we thought, well, we do something right, except that we stopped to do dexamethasone, but we continue to use high-dose methotrexate. But if you conclude in detail, and if you read the paper in detail, then it's obvious high-dose methotrexate with leucovorin was compared with methotrexate without leucovorin. And the Capizzi arm was used with asparginase, whereas the high-dose methotrexate arm was used with 6-MP. So we are comparing apples and pears. This is not a methotrexate question. So the headline of the paper is a little bit misleading. Well, nevertheless, there's an advantage in favor of high-dose methotrexate, and even in slow early responders, even more. There was also less mucositis, which is amazing, it's surprising. and there was an interaction with the induction corticosteroid, as mentioned. Okay, in the next study, which was published 2 years later, the opposite was true. TL0434. You see the line here? It's a p-value of 0.04, but the outcome is actually quite similar. Anyway, again, continuous Capizzi, methotrexate, not continuous. Capizzi, methotrexate, yellow line. It's a different color now. Capizzi, methotrexate is a little bit better than high-dose methotrexate. And you think, this is not what we expected. Why is this the case? Then they looked at the different risk groups in low risk, intermediate risk, and high risk patients here on the right side. And the effect was significant in disease-free survival in intermediate risk patients and clearly advantageous in high-risk patients. Surprise, surprise. So, what to conclude? Again, high-dose methotrexate with leucovorin and 6-MP was compared to escalating methotrexate without leucovorin and PEG asparaginase. So these patients had just simply more asparaginase. And a second point, which you can only detect if you go into the detail of the paper, the cranial radiotherapy was so different. Both groups were irradiated, but the ones who had high-dose methotrexate, they got irradiated much later, at month 6 months after diagnosis, whereas the other ones were irradiated early on. This has certainly an impact on the disease in the CNS. So, nevertheless, in contrast to high-risk BLL, a significant advantage was found in disease-free survival in favor of Capizzi methotrexate. Did we learn any lessons in BFM? I'm not sure. I will try to convince you. But obviously, we missed a unique chance many years ago. I'm too old to repeat this experience, and others may do this. We never randomized really methotrexate alone, 0.5 grams versus 10 grams. This would have been a wonderful randomization, but nobody wanted to do it in '86. In '86, we designed this protocol, and we thought, well, we are super smart. First of all, we skip delayed intensification. We skip 6 months of maintenance. We just introduce high-dose methotrexate. It will be effective. I remember very well Professor Riem was absolutely enthusiastic about this. And what do you say? I'm your pupil and I have a complete different opinion. No, you say, it's okay, we do this and we do very delayed intensification protocol S and more stuff like that. Well, unfortunately, this study had to be amended after a while because these patients, standard risk patients, had many more relapses early on because they didn't have delayed intensification. So we reintroduced that, and we also prolonged maintenance therapy. And then we looked here, of course, at the introduction of high-dose methotrexate. Previously, every patient in BFM received 0.5 grams. Now everybody received 5 grams. Initially, we used a very early leucovorin rescue because we were really not sure if it's safe enough. Then it was so safe that we changed the protocol to less leucovorin. We also skipped cranial radiotherapy, and we never used and have not even used at that time IT methotrexate in maintenance. And it was good because we had no increase in CNS relapses. In this subsequent trial 90, we thought, well, protocol M is very well managed. We can add asparaginase and we will improve outcome in general. Unfortunately, this was not true. As you can see here, the arm number 2 with additional asparaginase had no advantage in event-free survival, disease-free survival, overall survival. So this was not effective. I think it's not because of the methotrexate, it's because of the insufficient asparaginase regimen at that time. We didn't know much about this drug at that time. So there's something missing here? No. Then we introduced RRC in the exactly same time of the protocol. and this was 24 hours RRC given directly after methotrexate. Unfortunately, again, a randomization with exactly the same outcome, which means why do it? And you can skip it. So we skipped that. We also skipped radiotherapy, not only for standard risk, but also for medium risk patients, which was good. And we did another randomization, which is the blocks with DEXA and vincristine in 1,500 patients. This randomization also delivered a very nice result because it showed we don't need blocks in such patients. So, again, additional drugs on top of methotrexate, such as RRC, are now beneficial for the disease-free survival, but there is significant toxicity in terms of myelosuppression. It was safe to omit radiotherapy. It was safe to reduce radiotherapy for T-cell ALL and high-risk ALL, and we didn't show any benefit for the pulses. Then let me quickly turn to non-Hodgkin lymphoma, because there I found the only study in which the dose has been compared, 1 gram, and no, not the dose. The schedule has been compared, 4 hours versus 24 hours. Adisha, were you already at work?
Not really. I noticed.
Okay.
I started studying.
See.
Okay.
Sorry. Let's joke off on elderly. In this study, this was risk stratified by stage and degree of resection of a Burkitt lymphoma. And overall, I'm only focusing on the duration of infusion. It was compared 4 hours versus 24 hours. There was a significant advantage of the longer exposure time. So to do 5 grams or 1 gram with 24 hours seemed superior. We looked at it by stage, and the lower stages, in lower stages, we could not demonstrate that disease-free survival was better with 24 hours infusion time of methotrexate. So one can skip that. But in advanced stage Burkitt lymphoma, this is a major point. 24 hours infusion time gives you a better than 90% disease-free survival. So to conclude, first of all, I want to apologize to those in the room of which I did not show any data. Probably I'm also too stupid to see all the data, because I think it was more than 2,000 publications that I found on PubMed, and I was not able to look at all of them. You may still do that if you want to. We know that there are, as to my knowledge, no comparative studies available comparing low dose, intermediate dose, or high dose methotrexate in pediatric ALL regimen. But we think we know a few things. Systemic and CNS disease control can be achieved by several cycles of high dose methotrexate if other components of therapy are fully functional. Why I'm saying this? If you skip delayed intensification and you hope you can use just high dose methotrexate, as we did in the 80s in BFM, it's not a good idea. It will not work. And of course, there's a second very important thing. You need to measure the levels. If you cannot measure levels, and I know many countries in which this is not feasible, it's not a good idea to use high-dose methotrexate maybe. Leucovorin needs to be used in low dose, not too frequent, and rather late. There are 2 different doses depending on the product that is available. I think it may be feasible to skip IT methotrexate in maintenance therapy. But Capizia methotrexate is also a very effective approach. And in the future, BFM and AOP are considering to come to this regimen for our low-risk patients in whom we plan significant, heavy treatment reduction due to the introduction of immunotherapy. So what do we do currently? Currently, we use 5 grams 4 times every 2 weeks, 3 doses of leucovorin, always with IT methotrexate at hour 2. And in the high-risk blocks, we use it in blocks number 1 and number 2. That's all. I know it was too long, I guess. So thank you.
Yeah, thanks a lot, Martin, for this very, very nice talk and guiding us through the history, which I always think is very important to know about when developing new trials. So are there any questions or comments in the audience? Please.
Of IT methotrexate, how important is to give after you start the perfusion in concordance with the level in the CSF?
At the beginning, I think we were completely convinced that you need to do it exactly at hour 2. Today, I'm more relaxed.
We know your protocols.
Yes, and in the lymphoma protocols, it was always funny. We were used to give it at the end of the infusion at hour 24. I think the most important thing when you apply high-dose methotrexate is to be on the safe side, that nothing goes wrong, that the nurses know exactly what you do, that they take the blood sample.
Okay.
Exactly. For the CSF concentration, the IT methotrexate increases the concentration in the CSF, so it doesn't make sense to give it many hours after the infusion. Then it's...
And before the infusion?
You can do it before, but then you will maybe not reach the same
level of CSF. Thank you very much.
Thanks a lot. Any other question or comment? Perhaps I can ask a question, Martin, to you, but also Valentino. You both know very well that in the IOP-BFM 2000 trial, one of the very few differences between Italy and BFM was that you used 2 grams per square meter methotrexate over 24 hours in protocol M for BALL. And we used 5 grams, and we saw a difference when we compared the outcome of both groups. Do you think this could have played a role or not?
Oh, I'm sure it played a major role. No, I'm kidding. We don't know. And you know that we don't know. As I said at the beginning, we do not know many things. I'm not 100% convinced that this is due to the dosage.
You would like to say something?
It has just been published by the ALIC group in JCO, the paper just published now, that they did not find any difference in this subgroup of patients in the randomized study.
Okay, one last comment or question. Is it to Martin? Yeah.
Hello, so I'm from India. Now, TLL, we have seen that many groups are showing capacity to be at least equally good as high-dose methotrexate. What is your take on high-risk BALL, where previously COG had shown that high-dose methotrexate is superior? Can it be substituted in high-risk B as well?
Well, as I mentioned, the comparison, unfortunately, was not on the dose of methotrexate. It was a combination of drugs in one arm and another combination in the other arm. Therefore, a clear answer to your question is not possible based on the evidence. If you really want to compare 0.5 grams with, let's say, 5 grams of methotrexate, you have to find a study or do it yourself, because as long as you introduce 6-MP leucovorin in one arm and asparginase 2 doses of PEG in the other arm without leucovorin, you compare apples and pears.
Okay, thanks a lot, Martin. Yeah, it's also a pleasure now for me to ask Chris Halsey to come on the floor. We are happy that you're here, and she will give a talk on the topic of MTX-related neurotoxicity, for which she has a long-time interest.
Thank you so much, Andisha. It's a real pleasure to be here and to discuss methotrexate-related neurotoxicity. So when we think about methotrexate-related neurotoxicity, this is related to all forms of methotrexate, so intrathecal, high dose, and in fact, even in some non-malignant protocols with oral methotrexate for things like rheumatoid arthritis, although the much lower dose means that this is much less common. So in terms of methotrexate neurotoxicity, we really are looking at a spectrum of conditions from an acute episode related often to high-dose intrathecal therapy, which can cause nausea, vomiting, somnolence, and headache. And that was more commonly seen a few years ago when we used much higher intrathecal doses, less common nowadays. But the most common thing we see is a subacute form of neurotoxicity in the form of stroke-like syndrome or seizures that usually occur between 2 and 21 days after methotrexate exposure. But we also know that there are significant instance of asymptomatic leukoencephalopathy picked up on MRI scanning, and also that we have problems with chronic neurotoxicity, mainly ascribed to methotrexate use. So just going through these in turn, methotrexate stroke-like syndrome really has a very characteristic clinical presentation. So those of you who've seen children with stroke-like syndrome probably won't forget it, in that they tend to present with, as the name suggests, something that looks exactly like a stroke, like a dense hemiparesis, present to the emergency department, but by the time the patient makes their way up to the pediatric oncology ward, you might find that some of those symptoms have actually resolved, but a new symptom has appeared, so they might switch from a hemiparesis to a facial nerve palsy or dysarthria or confusion, disturbed affect, etc. And this characteristic waxing and waning pattern is really commonly seen with this methotrexate-related neurotoxicity. And most patients do resolve within 7 days. The only really established risk factor is older age, so children over age 10. The Australian ARRAISE study also suggested that the raised AST in induction is a risk factor for stroke-like syndrome. And the UK data also suggested that it was increased if you gave intrathecal methotrexate alongside systemic Ara-C and cyclophosphamide. The diagnosis is often made by MRI scanning. CT scans are frequently normal, and there is supposed to be a characteristic appearance on diffusion-weighted imaging, although this is controversial. Interestingly, stroke-like syndrome often occurs after multiple exposures to methotrexate, doesn't clearly have a linear relationship with the methotrexate level, and it's usually safe to re-expose patients, suggesting that there's probably an interaction between both environmental and genetic factors. However, given that it's individually rare in each country, our knowledge to date has really been achieved from isolated case series. And so to try and shed a little bit more light on this problem by collecting a large number of cases, we've recently carried out a Ponte-Leño neurotoxicity study involving 23 countries globally, collecting all their cases of neurotoxicity on frontline leukemia protocols. And we've collected an impressive 1,813 cases across the diversity of neurotoxicity that we see in ALL. When we look specifically at stroke-like syndrome in this cohort, although we had about 250 cases reported as stroke-like syndrome, we were only able to confirm that 147 of them corresponded to our consensus definitions. So looking at these cases that we know are stroke-like syndrome and not potentially things like vincristine-related PRES, we saw a peak instance at 8 to 10 weeks of treatment. About a quarter were related to high-dose methotrexate and others related to intrathecal therapy, maintenance therapy, or Capizzi. Certainly was commoner during high-dose methotrexate blocks. There wasn't an association with intrathecal triple versus single therapy or protocols that used early versus late leucovorin rescue. And the reported radiological findings, as shown here, are really very variable. So as we expected, about 3/4 of CT scans were normal. The majority of MRI scans were abnormal, but our diffusion-weighted imaging showed a whole variety of increased and decreased diffusion, despite these being well-characterized stroke-like syndrome patients. About 90% of our cases resolved within a week, and 10% of our patients had a residual neurological symptoms that lasted more than 1 month. Switching from stroke-like syndrome to seizures, seizures are seen in about up to 10% of children with ALL, and about 60% of them are related to chemotherapy, pretty evenly between methotrexate and vincristine, producing PRES. It's important when a child presents with seizures to think that there are other non-chemotherapy related causes at play potentially, including intracranial hemorrhage, cerebrovenous sinus thrombosis, CNS infections due to viruses or bacteria, hyponatremia, electrolyte imbalance, and hypoglycemia. However, those who have idiopathic or methotrexate-related seizures are more likely to have leukoencephalopathy and subsequent neurocognitive deficits, showing that these really are a manifestation of global methotrexate neurotoxicity. And I think the most important take-home message from treating seizures in patients with ALL is that you really should avoid cytochrome P450 inducers. Elegant work from St Jude's many years ago showed that patients who were started on drugs such as phenytoin had a significantly increased leukemia relapse due to reduced drug levels of subsequent chemotherapy agents delivered. So we generally recommend Keppra as the treatment of choice in this case. I mentioned subclinical leukoencephalopathy, so this is some very nice data from St Jude's, Deepa Washwani, showing that in their cohort of 355 patients, nearly 4% of children had overt neurotoxicity. But when they did serial MRI scanning, they found that 21% of patients who didn't have any obvious overt neurotoxicity did have evidence of leukoencephalopathy on MRI scan. And importantly, 3/4 of those patients had persistently abnormal MRIs at the end of therapy. And when they went on and did subsequent follow-up studies, it was these patients who seemed to have longer-term neurocognitive and neurobehavioral deficits. And similar abnormal rates of MRI scans with leukoencephalopathy have been seen in lots of other cohorts, not just St Jude's cohorts, up to 50% of children having demonstrable leukoencephalopathy on MRI during treatment. So it's clear that the overt toxicity we see from methotrexate in the form of seizures and stroke-like syndromes is really just the tip of the iceberg, and that many of our patients have evidence subclinically of leukoencephalopathy. And that probably fits with the other data showing that if you actually follow children up longer term, anything up to 60% of children post-leukemia therapy have neurocognitive deficits in one or more domain, often things like executive function or attention deficits. And that's even in patients who are treated in our more modern chemotherapy-only cohorts. Even more worryingly, if you follow up and do MRI scans on children who had treatment for leukemia as a child and are now in their 30s and 40s, you see significant white matter volumes and changes that look really like accelerated aging within the CNS. So I think there's a real concern that we might be sitting on a ticking time bomb and that our children might be at risk of dementia and increased risks of dementia as they get older. But unfortunately, the optimal interventions and treatments for this chronic neurotoxicity are really unclear at the moment. You can do things like brain training programs, but these tend to just improve your performance on that program, but not in everyday life. So it's more important probably to have goal-orientated neuro-rehab where you identify the problems that the children want to solve and actually work on strategies to improve those symptoms rather than just try and do general cognitive training. And there is some evidence for ADHD medication in children who fulfill the diagnostic criteria for ADHD. So what causes methotrexate neurotoxicity, and can we use this information to try and prevent it? So we used to know very little about what really caused some children to have these problems and others to have no problems from neurotoxicity, and we knew that there was a relationship, obviously, to very high doses of methotrexate or very inadequate methylinic acid rescue in very early protocols, but more modern protocols with reduced doses of methotrexate intrathecally and methylinic acid rescue for high-dose methotrexate have really reduced that. There is some evidence for pharmacogenomics and drug interactions, and we know there's an interaction between methotrexate and cranial radiotherapy. But actually, recently, a lot of interest in this area from the adult field in terms of chemotherapy-induced cognitive damage, or what's called chemobrain, has really led to an explosion of mechanistic studies in this area, particularly using mouse models. And they've really identified that there's defective myelination due to inflammation and triglial dysregulation, and some significant markers of oxidative stress and redox imbalance in the CSF. In addition, we know that homocysteine is important, and I'll come and touch that in the next couple of slides, and also acute adenosine release. So the things that we have some evidence for are aminophylline and dextromethorphan, which I will discuss, but I think the upcoming area of research is whether antioxidants might have a role, and there's certainly promising preclinical data for antioxidants in mouse models, but they haven't yet got through to clinical trials. So what about aminophylline? So we do know that adenosine is increased acutely in the CSF following high-dose intrathecal methotrexate exposure or high-dose systemic methotrexate, as shown here. And the first study actually looking at aminophylline was from 1995, so a long time ago, and showed that you could get complete or partial responses to your neurotoxicity with aminophylline infusion. But if you look at the symptoms in this cohort, actually they are generally symptoms associated with acute adenosine release, like nausea and vomiting, rather than these stroke-like syndrome cases. In our Ponte de Leño cohort, we had only 12 patients that we had data on aminophylline. 11 out of those 12 recovered within a week, but that was the same as the rest of the cohort without aminophylline exposure. And the patients receiving aminophylline didn't have a significant difference in neurological outcomes or recurrence risk. So the data for aminophylline is not very strong. There's slightly better theoretical data that dextromethorphan may be important for stroke-like syndrome, particularly from animal models. And dextromethorphan essentially acts on the NMDA receptor and is a particularly attractive candidate because it's a common component of children's cough mixture. And we know that methotrexate inhibits the interconversion of homocysteine to methionine, and that prevents the building blocks for DNA synthesis, but it also leads to buildup of homocysteine, which can act on the NMDA receptor. Again, relatively old and small case series show that dextromethorphan has led to resolution of symptoms, but if you look at the duration it's taken to resolve, some of these cases may well have resolved anyway, given that we know that pretty much all cases resolve within 7 days. So really the data is from small case series. There are some significant drug interactions with dextromethorphan that you should be aware of. We think it's safe, but actually we should be careful in some patients. And there have been some case reports of prophylaxis for subsequent methotrexate doses, but really the efficacy of this approach is unknown. And unfortunately in our Ponte de Leño cohort, we had too few cases to really pull out any meaningful data. But knowledge of this interaction, this reaction that really tells us that dextromethorphan might be important, also raises the possibility that there might be some very easy things we can do to reduce methotrexate neurotoxicity. So I've already mentioned that methotrexate inhibits this interconversion of homocysteine to methionine, catalyzed by methionine synthase. And methionine synthase has an essential cofactor of vitamin B12, which is irreversibly inactivated by nitrous oxide. So there's certainly very good preclinical data and some data from adult patients receiving nitrous oxide therapy that concurrent use of methotrexate and nitrous oxide might potentiate neurotoxicity. But we also know that children with leukemia can have low B12 levels anyway due to enteropathies related to things like macrocaptopurine use. And we also know that drugs such as omeprazole can affect B12 absorption, and fluoroquinolones and piperacillin can also cause elevated levels of methotrexate within the plasma and the CSF. So avoiding well-known drug interactions may well be important for bringing down the incidence of methotrexate toxicity. One of the really common recurrent questions I get asked is it safe to re-expose when a patient has had an episode of neurotoxicity such as a seizure or stroke-like syndrome? And the risk of recurrence from many series, case series, is somewhere between 10 and 20%, and that was borne out by our Ponte de Leño large data set. We had a 19% recurrence rate on the patients where we had data on re-exposure, and this is even higher in patients with Down syndrome, particularly for seizures. However, the alternative option that many people like to think about is in switching to intrathecal cytarabine for CNS prophylaxis, but it's really completely unproven as to whether that affects outcomes. And this is data again from Mario Mateos and Toby Treher from the ARRAISE study, showing that patients where they had their intrathecal methotrexate stopped post an episode of neurotoxicity had a significantly increased risk of CNS relapse compared to those who continued with their programmed therapy. And that actually contrasts with our UK data, which shows that having neurotoxicity had no impact on your event-free survival. And in the UK, we're actually pretty religious about re-exposing. So generally, we would say that re-exposure is recommended once the patient's had resolution of their symptoms, because really you're balancing that with an increased risk of relapse. And if you relapse, you obviously then go to receiving things like cranial radiotherapy and transplant, etc., which are far more neurotoxic. But it is sensible to ensure that patients that you're re-exposing have optimal fluid and electrolyte balance, that their B12 levels are normal, and that you've avoided all the other potential precipitants. People have tried giving some folinic acid rescue post-intrathecal therapies when on subsequent re-exposure or prophylactic dextromethorphan. We certainly found in our Ponte de Leño cohort that those who had supplementation versus those that didn't seem to make any difference to the recurrence risks, but the numbers were really small. So just looking to the future, I think we're now at a position where we might be able to think about intervention studies to reduce neurotoxicity, potentially, but specifically because we have some new tools. And there's a software program called Cogstate, which consists of a series of computer games that children can do with minimal supervision. You don't need neuropsychologists, etc. And they seem to be pretty sensitive at picking up children with early evidence of cognitive problems. So this was pioneered in the Dana-Farber study by Stephen Sands and Peter Cole, and they've shown that at the end of therapy, about a third of patients show one or more of these neurocognitive tests at greater than 2 standard deviations beyond the mean. And we've been carrying out in the UK a neurotoxicity study that's combining Cogstate measurements with CSF measurements and also genetics to see if we can pull out a group of children at particularly high risk. And we're continuing this in the Altogether protocol. But I have to say, I think probably the biggest way to prevent methotrexate neurotoxicity is to try and reduce the use of methotrexate and find a drug that potentially can give us really good CNS prophylaxis without all the attendant toxicities we see with methotrexate. If we can't do that, at least we might be able to try and modify the methotrexate dose according to people's risk of relapse. And for that, we need really better biomarkers for CNS relapse and for CNS involvement and response to therapy. And I just want to draw your attention to CSF flow, which is an altogether study using flow cytometry to see if we can better identify children's risk of CNS relapse and therefore randomize a reduction of CNS-directed therapy. We're really looking for this Goldilocks point where we're balancing the risk of CNS relapse versus toxicity to give each child just the right amount of therapy. So I'll finish there, and I'm very happy to take any questions. I just wanted to thank all the people who've helped with this work.
Yeah, thanks a lot, Chris. It's always very nice listening to your talks. So any questions or comments from the audience? Martin.
Chris, the number of IT methotrexate installations and the intervals between the IT methotrexate interventions, what impact does it have on the neurotoxicity?
So it's a good question. I mean, I think a lot of the data comes from really quite old protocols. So it's quite clear if you use high dose is intrathecally and with very short intervals, then you can get really significant levels of neurotoxicity. And some of the early COG trials were stopped. Well, it was before it was even called COG. So the pediatric oncology group trials were stopped because of really significantly high rates of neurotoxicity. In our modern protocols, where we're giving intrathecals at least a week apart, it's really much harder to disentangle the effect of dose and intervals on those neurotoxic outcomes. But we're hoping, so in Altogether, for example, we're doing Cogstate measurements on all patients. So we should have 6,000 Cogstate measurements, and then we can really start to try and disentangle different treatment arms and their impact on this level of neurotoxicity. Because up till now, we haven't really been systematically measuring it. It's not now, we do echoes on our patients, but we don't do neurotoxicity evaluations. So it's much harder to pull out these things.
Next question.
Vasilios Papadakis, Athens, Greece. Thank you for the excellent talk. We do not do MRIs in all patients at diagnosis, and once we do, for baseline or other reasons, we find some degree of atrophy, meaning gray matter decrease in thickness. Have you taken into account that effect, that disease presents with some kind of neuronal problems?
Yeah, it's a really interesting question. And as I was saying, some of the adult studies from ChemoBrain have really shown that inflammation is a very important component of the neurotoxicity that you're seeing. And it's likely that the presence of CNS leukemia actually has quite a significant inflammatory effect in the brain.
Yeah, but we see even without CNS disease by counts and flow.
Yeah, so I mean, leukemia itself is an inflammatory state, and some of that will cross the blood-brain barrier. It's likely that most children do have subclinical levels of CNS leukemia as well. But it's certainly, there's certainly an important point that these children are probably predisposed, even without our treatment, to neurotoxicity.
Thank you.
Any other questions? Martin again, and then two questions.
Oh, sorry, not a question. This was focused on neurotoxicity, and I think that was fantastic. But what one should mention is that IT methotrexate is not only potentially neurotoxic, it also has a sustainable systemic effect on the body of the patient. We just published this week or in a few days a paper in which we demonstrate that there are more sepsis cases and patients even dying in those who had more IT methotrexate. That's why precise diagnosis of CNS involvement is important, because you may treat the wrong patients with additional doses, or you may skip the additional doses.
Yeah, agreed.
Yes,
hi, this is Martha Basul from the Royal Marsden in the UK. In the UK, we do tend to re-treat with IT methotrexate after resolution of symptoms. But once you have a second event, then we change to IT, cytarabine, hydrocortisone. How does this change the numbers and the prognosis of the patients?
Yeah, so completely unknown, and actually it would be a very good idea to collect data on that, because I think there probably are sufficient cases, certainly if we do a kind of Ponte de Legno type effort. The difficulty is knowing what your control group for that is, but I think we just don't know whether intrathecal cytarabine is effective, and the numbers are too small to really pull out that data with what we have at the moment. Unfortunately, our Ponte de Legno toxicity cohort wasn't powered to look at that, so it would require a different data collection. But it's a very good question.
Perhaps I'm not right, Chris, but usually these stroke-like syndromes occur only once in the patients and usually don't recur very often.
That's right. So the recurrence is mainly seizures. They do occasionally happen a second time. Seizures or non-specific kind of encephalopathy.
Last
Miguel
question,
Martins from the Portuguese Institute of Oncology, Lisbon, Portugal. I was wondering, when these patients have seizures, or if they present themselves with seizures, do you give them also anti-seizure medication, and do you do that for a period of time after it? And if so, would you consider it doing prophylactically when you reinstate MTX afterwards as well?
Yeah.
Could that be something to also consider?
Yeah, so that's an excellent question. So in the Ponte de Legno cohort, about 50% of seizures were just a single seizure episode. The vast majority, I can't remember exactly, maybe 80% were all terminated within 24 hours. So not all children need ongoing anti-epileptic, anticonvulsants. It's highly recommended for children with Down syndrome. We know from that cohort that 7 out of the 8 Down syndrome patients who were re-exposed had a recurrence of neurotoxicity, and we know that from other treatments such as blinatumomab as well. Otherwise, I mentioned about the dangers of anticonvulsants. Many patients with leukemia have huge polypharmacy. You add in something else into the mix that might also have its own side effects. So I think it very much depends on whether the first seizure was self-limiting, self-terminating, whether there were other obvious causes that might have been contributing. So was the child febrile, had low sodium, etc. If it's just a significant seizure with no other precipitant, then probably anticonvulsants are indicated. But if you could see another cause, then probably just optimizing that and making sure that you have a normal sodium, etc., at the time you re-expose is probably sufficient.
Thank you.
Okay, thanks a lot, Chris. I would like now to hand over to my co-chair, Martin, to introduce his long-term friend, Valentino.
Yeah. Well, it's a big pleasure to introduce Valentino. sorry, Valentino. Valentino is indeed one of the most experienced people in ALL research, and he will address an issue which I touched briefly. When you do methotrexate therapy, what do you do if you have a real emergency?
Well, thanks, Martin, for the introduction. Thanks, Andisha, for organizing this meeting. Okay. Have no conflicts. First, the title. The title gave me, Andisha, is there an indication for carboxypeptidase? Is this only one enzyme? Actually, carboxypeptidase is a quite interesting and composite biochemical situation. There are many carboxypeptidases, which may be as sources mammalian or from insects, mitochondrial or bacterial, fungal, and recombinant. And there are a list of letters that go from A to XYZ to classify carboxypeptidases. And within these subtypes, for example, of type A, you have A1, 2, 3, 4, 6. So what we are talking here is not just a carboxypeptidase, but is a glucarpidase, which is part of a carboxypeptidase G. And within this, we have also different types of glucarpidases. There was glucarpidase G1, we will talk briefly. Glucarpidase G2 is the drug voraxase, voraxase, I don't know how we pronounce it. And then we have a G3, which has antifolic, anti-tumor activity. And there are also novel glucarpidases, which seem to be not cross-reactive in terms of immunology with the current glucarpidase G2. Now, what do carboxypeptidases do? They cleave a peptide bond at the carboxy terminal of a protein or a peptide. While carboxypeptidase G1 or G2 glucarpidase cleave methotrexate in glutamate and DAMPA, as shown here. From the methotrexate is split into glutamic acid and DAMPA, which is pteroic acid. Now, a little bit of history. Methotrexate was introduced in treatment in the 50s, and already in the 50s it was recognized that could be inactivated by some defined, not exacting bacteria. In the 60s, there was a partial purification of the enzyme which catalyzes the cleavage of glutamate from aminopterin or methotrexate, and that was extracted from Pseudomonas. In the 70s, this product, which is classified as carboxypeptidase G1, was isolated from Pseudomonas statzer in 1967, published in 1968, was administered to patients with brain tumors and to one patient with renal failure, showing that this compound has activity to cleave methotrexate and thus could be used to prevent toxicity. This compound is no longer available, and the drug we are talking now is available, was actually cloned. The gene was cloned in 1983, derived from Pseudomonas species strain RS16 and cloned into Escherichia coli. And it's available, the drug, for compassionate use since 1993. Was approved by FDA in 2012 and in Europe 2022. What does voraxase do? It is demonstrated clearly that in 15 minutes can safely eliminate more than 95% of the drug from the blood. So it's impressive, this activity. Of note, when we measure the levels after having used voraxase, to have reliable results, we should use either HPLC or mass spectrometry because the immunoenzymatic method measures together with methotrexate also the subproduct DAMPA. Now, how much is it used? I show here an experience, some data from a survey done in Italy. It was looked over 6 years, how much it was used in ALL or non-Hodgkin lymphoma. And in this 6 years period, it was given to 16 patients. This means approximately 2-3 patients per year. And in this period, we can estimate that in Italy we had approximately 2,500 patients, and that approximately 10,000 courses of methotrexate have been administered to patients with either ALL or non-Hodgkin lymphoma. Now, in 12 out of the 16 patients, a complication occurred at the first high dose methotrexate. Median glucarpidase administration was 48 hours. Most patients were in the time frame which is recommended by the SPC. Patients in 14 of these patients had also acute kidney injury, and this does not mean exactly failure, but acute kidney injuries was obviously a main trigger to decide which patients should receive the drug. And in fact, median creatinine level was 2.5 in these patients, milligram per deciliter. All patients had some other toxic event, which could be, besides acute kidney injury, they developed also liver or skin, mucous or bone marrow and gastrointestinal toxicity. One patient of these 16 died of sepsis, and this was due to an infectious complication. 15 patients fully recovered, and 8 of them received further methotrexate, however, at lower doses than the dose they received when they presented the complication, which was treated with glucarpidase. 14 of these 16 patients are alive and well. This is the experience published by St. Jude. They used glucarpidase in 1.8 of the patients presenting with delayed methotrexate elimination. Courses were distributed. The methotrexate complication was distributed in different courses. The patients were treated with borax at a median of 46 hours, and 13 were re-exposed. Now, need and benefit. Certainly very slow clearance associated with acute kidney injury may be a life-threatening complication. The availability of glucarpidase for these patients may be a life-saving procedure. Glucarpidase should be given at the appropriate time and possibly within 60 hours from the administration, from the beginning of the administration. But what is the real need? These are taken from the SPC. Methotrexate can be given at different doses, as Martin showed, from 1 to 5 grams. We talk of for ALL as high doses. It may be at higher doses for lymphomas, particularly if they have CNS involvement, and for osteosarcomas. And this is taken from the SPC of the drug, which suggests to administer the drug for all patients who are treated with different levels and different timing according to the level of methotrexate. For example, if we take patient receiving between 5 and 8 grams meter square, if 42 hours, which is a common value in monitoring, is more than 10, you should give it according to this indication. I looked at a few data we have from our center. I think that if we follow these guidelines, these recommendations, probably something between close to 5% of the patients may have the indication to the drug administration. Now, what is the toxicity we encounter when we use the dose of methotrexate 2 or 5 gram meter square? It has just been published on JCO in a very interesting leak paper where patients with BALL were randomized to receive either 2 or 5 grams in 24 hours for cycles each. Glucarpidase was not available in the country where this treatment was given. Kidney failure, which I don't know how exactly this is defined, but anyway, this was reported in 2 patients receiving 2 grams and 1 receiving 1 gram. Infections were reported in 3% versus 1.5%, and deaths in this over 2,000 patients occurred in 2 patients, 1 in each arm. This shows that this treatment phase is in general very well tolerated altogether, and as Martin showed before, this phase of treatment was used in the past to test if additional treatment, which is could increase toxicity, was feasible, acceptable for toxicity, and would improve outcome. The 2 and 5 grams, as mentioned by Andische, can be seen also in the IEOP experience. In the 2000, we used the 2 grams, and we have 1,500 patients who were in the non-high-risk patients, and this patient treated with 2 grams square meter were treated without monitoring the levels, and glucarpidase was not available, I think, or not known to be used in any of these patients. We have 1 patient with 1 kidney failure, and no patient died in this phase, protocol M. I'm not talking here of the patient at high risk where high-dose methotrexate is combined with multiple drugs, and there the toxicity cannot be evaluated by methotrexate itself. In the 2009, we used the 5 gram square meter and with levels, and in the survey I showed before, it seems that 10 of the 16 cases who were collected belonged to the study. And but if I look at the patient who had the levels of 10 just at that point, at 42 hours micromoles, after 42 hours, 3.3% of the patients qualified for the treatment with glucarpidase. The schedule is clearly altogether well tolerated. Here, too. 1 gram square meter, I'd like to show this data, is from Central America, based on the experience of the RETH study in Germany. We introduced there the methotrexate at 1 gram square meter in 36 hours in the frontline therapy. There are about 1,000 patients treated, and there are no reports of severe kidney toxicity. Now, there you may have a higher mortality rate, but that's due to the local situation. So, what is the need? AKI is acute kidney failure, acute kidney injury is reported probably in approximately 1% of the patients. However, there are different levels of kidney injury. Methotrexate clearance at the levels which could benefit from glucarpidase, according to the indication I showed, might be around between 3 and 5%. The real use in Italy is of 2-3 cases per year, and I think that would increase probably by approximately 10 times, more or less. The schedule obviously is very important. Timing of methotrexate duration is very important, and in some context it is used, for example, at St. Jude, it seems to be close to 2%, but that's the situation there. So, to summarize, toxicity caused by medication is certainly hard to accept, and that's the problem when we are talking of using a drug which is an antidote for the drug we gave. The indications by SPC, as I said, are rather extensive. Many protocols do not give any indication on how to use glucarpidase. How many patients should be treated remains a question. Most crucial cases are those associated with kidney injury, and probably patients at older age, as mentioned Martin, but also those who are treated with TKI may be at higher risk. The last slide, I think the drug is safe. The indication, as I said, may be about for 5%. The absolute need may be less than 1%, taking into account that the cost is almost 30,000 euros for each patient, and depending on the weight, you may need 2 vials. Just thank Carmelo Rizzari, Miriam Campbell, and Daniela Silvestri for providing me some of the data I showed here. Thanks for attention.
Thanks very much, Valentino. Is the duration of hydration before you start methotrexate and the levels of the creatinine relevant to predict kidney failure?
That was part of your presentation, I think, but definitely yes. The attention to hydration and having also nurses who are well trained in keeping, as mentioned also in the previous presentation, is crucial to reduce the risk of intoxication by methotrexate. But I think many cases are really unpredictable. One caveat you may have, and this is done in our center, is to check creatinine during the administration of methotrexate. If you see that methotrexate is increased after 12 hours, certainly it's this should suggest, should be a recommendation to discontinue the further administration of the drug. I don't know if would you have other recommendations, or you, Andisha?
No, I completely agree with you, and I think that the kidney function and toxicity is the most important factor to take into account when thinking about glucarpidase. And the SPC, as you correctly said, is only dealing with methotrexate levels and not with any other factor that is important to decide to give the drug or not. So I completely agree with you.
More questions, please?
Specifically about the renal failure, because most protocols don't actually say, and even altogether it says it can be used if there's acute renal failure, but there are several different stages, so it's very difficult for us to assess if we should do or not glucarpidase, because it's a very expensive medication as well. So one of the things I think should be, or something to consider forward in these protocols, would be exactly when, like a table or something, when we should or should not use glucarpidase in terms of the levels of creatinine afterwards.
You're right, but it is very, very difficult for a protocol to give a recommendation based on what I said. I would say, as a personal experience, if I see that the creatinine is doubled after 12 hours, that could be a criterion to discontinue the infusion of methotrexate, but somebody else could have a very different
I could add that the urine excretion is even perhaps more important than the creatinine level. If the urine excretion decreases significantly and you see that the creatinine level has increased,
MTX.
then during the MTX infusion or after, and you have a high level, then you can get into a very dangerous situation. And then you should think about using carboxypeptidase.
So you're recommending for us to use the measure of MTX in the urine?
No,
right? No, or
the urine excretion.
Oh, the urine excretion, the FNA. Okay, thanks.
Okay, thank you.
Okay, thanks very much to the speakers for your attendance and enjoy the meeting any further and the city.